So welcome. I mean, I'm very pleased to be here. This actually is one of the best i2b2 installations for what i2b2 was originally conceived to be. So i2b2 was originally conceived to be a way to get the data that was really locked into healthcare into the hands of researchers, right? So that researchers could look at the data, not data analysts. I know a lot of you are data analysts, but that's not that. i2b2 is really so that the researchers could look at the data, the clinicians could look at the data, right, and get ideas like you've got right here about what to do with the healthcare data. So, and that. What's really tragic is, so you'll see we have lots of different i2b2 installations around the country and actually around the world, but not all of them actually allow the query tool to be used by the actual researchers. They'll use it within their own analytics department, which is just kind of weird, right? Because that's not that was not what we built it for originally. We built it so that we could get data into the hands of researchers. So there we go. So the point of using any data, I think, in fact, is understanding medicine, right? And the way that we have looked into understanding medicine recently, and there's a long history of how these things go. Different things come and go in terms of how trendy they are and how we talk about them. But I think medicine has always been, whether we call it precision or personalized or whatever, it's always been about how we manage a patient. And it's absolutely the patient that's in front of you that you need to manage. But the fact is that you need to understand how to manage that patient. You have to take the whole pool of patients, right, that exist that you in the past that you ever saw, right, which would be like maybe 1,000, right, and try to take the patient that's in front of you and kind of understand that patient in front of you from that pool of 1,000 and say, oh yeah, I saw a patient that was kind of like that, right, and he had some of those same kinds of characteristics, and he seemed to have a lot of kind of similarities, right? And so we tend to do this kind of exercise over and over, where we look at a population of patients and then we kind of divide them into two different groups, perhaps, that will respond in theory differently to our treatments, whether it be surgery, whether it be medicine, whether it be counseling, right? And so a lot of what we do is what we call subpopulation stratification. That's what we do in medicine, right? We've done it for hundreds and hundreds of years. And the point is that then we can actually target some of our treatments. And we, of course, want them to be based on evidence. And we also are interested in this thing called predictive analytics, right? So by looking at similar patients, we can kind of understand what's going to happen in the future because we know what happened to other patients that were kind of in a similar situation. So getting right down to it then, the problem becomes that we just don't see enough patients in a lifetime, right, to be able to do that, because patients come to us with thousands of different diseases. So even if we see 10,000 patients, 20,000 patients in a lifetime, we're only going to see a few patients that might be like that patient. So having a tool, right, where you can actually look at millions of patients is going to be very valuable. And we do this in a very organized way called a clinical trial, right? So we try to understand data from clinical trials. And you can see from how results come in from clinical trials why it's so important to have a very, very large population to be able to look at, right? So here, for example, is a whole set of trials. So going down the list there are just one trial after another. They're getting bigger and bigger as you go down the list. And what they're trying to do is measure the effect of the PPAR gamma gene variant Pro12-ALA. And what that is, there's a nuclear protein that people thought might be involved in diabetes. They had some early evidence that it was involved in diabetes. And so they did a clinical trial where patients with that specific variant, and they exposed them to different types of stressors for diabetes. And it seemed to actually be protective at first in the small trials, but you can see the error bars were so ridiculously large that you couldn't tell. And it kind of wandered, and then it was like, no, actually it's causing diabetes. And it wasn't until you got a lot of patients for your clinical trial that you actually could figure out the answer, which was it was protective. And of course, many of the medications that we use for diabetes is actually based on this protein today. So figuring this out is important. And when we started back in 1997, trying to understand what to do with healthcare data, there was no such thing that we could look across patients and gather up data, kind of like we do for a clinical trial. And so what we wanted to do was create this high throughput method, right, for supporting these kinds of translational research, where we could have a method that we could approach using the whole population that exists in our healthcare system. And actually, now it's kind of like the whole population across the country, by using some kind of high throughput tool where we could get sets of patients and select them using medical record data in this high throughput fashion by actual clinicians and researchers who understood the problem and were trying to cull out from their own experience often, important questions that they could get answered by looking at large numbers of patients. And then investigators need to take deep dives, right? So it's good to get your patients together in a cohort, but then you have to take a deep dive into the data. And so different ways that you can actually use something like i2b2 to take a deep dive into the data and understand the phenotype of the patient from the medical record. And that's actually a very challenging task. And then once we have those things down, creating a bigger network of patients that crosses institutional boundaries that we can actually use to look at questions in an even bigger way. And finally, take this all back into clinical care and personalized medicine. So let's look at the first one. So the first one is, how did we actually go about, even thinking of putting in the hands of clinicians and researchers the ability to find cohorts of patients? And at Partners, we kind of got together and created a tool that was going to be able to find patients in the record using medical records that fit certain profiles. And really, the early use was just to get to step one, find cohorts for clinical trials, right? If you can get enough patients that are similar for your clinical trial, then you can kind of take this organized approach from there and kind of not use the medical record anymore. But just getting those patients together is very challenging. And the high throughput way was really in these two steps. The first step was to allow patients to have their data, right, in a way that preserves their privacy. And this is very critical, of course, because when you're looking at lots of patients, there's going to be a lot of opportunities for the privacy to be infringed on the patient. So a tool had to be created that allowed researchers and clinicians to go in and query the data that might be in a very large database, but in a way that's de-identified as far as you can't find out the identity of the patient in this first step, because you're looking at, you want to look at data, you don't want to be encumbered by having to get an IRB approval every time, right? We had to get an IRB approval to set that whole step one up, but you don't want to have to get an IRB approval every time you want to look to see if a trial is even feasible, right? Or a study is feasible. So we ended up putting all the inpatient and outpatient clinical data, 1.6 million Partners patients, 2.7 billion diagnoses, medications, genomic data, procedures, laboratories, physical findings into a large database, authorized its use by faculty status, so that clinicians and researchers could construct the complex queries that you're familiar with, such that you do in i2b2. And this is a totally new idea in those days. There was no concept that that would even be possible. And it took us a while to actually get it right, I should say. So we kind of experimented with the researchers and clinicians at Partners Healthcare in order to get the tool to the point that it actually was intuitive enough that that the researchers would not. So the requirements were that it had to be so easy to use, right, that you could just look at the thing and be able to figure it out. Because they're not going to read any documentation. They might talk to somebody who knows something about it, right? What they're really going to do is they're going to fire up the application and they're going to click around, right? And they're going to try to figure out from that how to use the thing. And then if it seems interesting, maybe they'll read some documentation, and a lot of times they won't, frankly. But it had to be easy enough so they could at least get started. And so that was the goal, and the idea then was to come up with that query tool. Now it's very clear that that's not the end of a study, right? That's just the beginning. Once you figure out the cohort of patients, you're going to have to take a deep dive into that cohort. And at that point, we go to step 2. And with an explicit IRB protocol, which unfortunately can often take weeks and weeks to actually get through our IRB, you can get the identified patient data, where they will give them very large files of information about all the different diagnoses, provider information, reports of all different kinds, like discharge, LMR, which is our outpatient medical record, or was our outpatient medical record, radiology reports, and we'll package some of this into an Access database if it'll fit, Microsoft Access database, just so they can look through it kind of quickly. But in general, at that stage, they put it into something like SAS or R or something of that nature. So there's always these 2 steps: querying for feasibility, kind of getting familiar with the data and what's available in the healthcare system, and then returning the data when they figured out what their real study is, returning the data so they can look at all the data and do a complex analysis of it. And so the query tool we eventually settled on was this, and many of you are familiar with this in the room, where we have the query items on the left, and you can add query items as they come in, right? It's not limited in any way to the standard data, that comes in an EMR system, right? You can get data from NLP and put it in as facts, right, in i2b2, and that can be added as a query item. You can get genomic data, what we'll look at, and you can add that as a query item. So there's many different, anything that can be digested into a fact, right, about a patient can be put over here in the left panel. And then in the right here, this is trying to be a Venn diagram, this query system, where each box is, think of it as a circle of a Venn diagram. And so, but the first instance of this was built in Visual Basic. I couldn't really figure out how to make circles in Visual Basic, and so we used the box. But it's the circle. And so if you put 2 things into one circle, i.e. box, it's going to logically OR them together, right? So you want to find all the patients who have diabetes and hypertension, and you put the diabetes and hypertension into one box. You're going to get all the patients who have diabetes or have hypertension. It's not what you wanted, but that's what you're going to get, right, when you push run query. If you want the patients who have diabetes and have hypertension, then you have to put one in one circle of the Venn diagram and one in another circle, and then you'll get the intersection of the 2. And of course, you can get as many circles as you want or boxes as you want. And this idea that you could make these complex queries. You could do negations, you could do temporal constraints. Kind of started with just, the idea that they're working on a Venn diagram. And so researchers and clinicians were really able to kind of catch on to that because it's a very reasonable concept for them to be considering. And so at the end of the day, you get queries that look like this, where here you have an EGFR gene, and these are all the variants that are protein altering, and all the patients who have a respiratory malignancy, right? And this is an AND query, so these are all the patients in the system who have a respiratory malignancy and have a variant in their EGFR gene. And then you say run query, and you get this 269 plus or minus 3. So what's the plus or minus 3 doing there? So, so the first thing is you think, oh, that's the air in the system. But actually, as you're going to see in a bit, the air is much greater than that, right? So it's not even close to the air in the system. It's much smaller than the actual air. What it really is it's the amount we purposely blur this number. So that when you run the query, let's say the result is actually 271. We have a Gaussian of with a sigma of 1.7, and it will randomly pick a number in that Gaussian curve, which is more or less with that sigma going to be from -3 to 3, and add that to your answer. And so first you'll get 269, then you'll hit run query again, you'll get 270, then you'll hit run query again, you'll get 272, then you'll hit run query again and you get 268, then you'll hit run query again, and then it'll lock you out. And the reason is that, and that lock turns red, and the reason is that, of course, if you did that forever, you would converge on the exact number of patients, right? And the intention of this is to not allow people to get their exact number of patients for a query. Pretty close, right? You can figure out if it's a feasible study or not. But by doing that, this is rich clinical data that you have here, right? So it's going to be very easy to home in on one patient if you don't have that feature. Because patients with this rich data are you're going to be able to do a query, and it's going to be able to home in on a very small set of patients. And so that's what prevents that. And that's obfuscation. And that obfuscation is, so there's a big literature on it now called differential privacy, and you can kind of, but the whole idea is just that you add this noise to your system, and that prevents you from at this level, right? Now, in step 2, you're going to get all the data, right? So it's not like you're never going to know who these patients are. If you're doing a clinical trial, you're going to have to know who the patients are, right? If you're going to recruit them for a study. But at this level, where we're just exploring, right? We don't want to be encumbered with invading the patient's privacy, right? And so that's what that's all about. And then we do some very basic breakdowns, still with the obfuscation applied, in order to get, give an idea of what the demographics of the population are. Yes?
Is the concern of getting the exact number that someone could figure out who the patient is? And I could figure it out myself based on this example.
So that is the concern. So the concern is that you could figure out who the patient was. So I'll give you an example. So it's a limited data set that you can query by. So you can actually have zip codes in there. And you could say, okay, I want everybody in zip code 020353 who has, who's a male, right? And is 52. You'll get 3 people. Or let's say you get 7 people, okay? And then you go in and you say, how many of those have HIV? And you get 3 people. All right. So at this point, if you had something that said, okay, if you just eliminate everybody that's like, just don't report any answers that are less than 2 people, right? You'd be like, well, then, you'd be fine. But let's say now you add 02053 zip code and you add 02054, right? Which is actually the city right next to it. And you get one more person, okay, who's a male. You know who that person is, right? So now your answer is you have 8 people, right? You had 7 when it was just 02053. When you added 02054 into that OR, you got 8 people. And now you say, how many have HIV? And you get 4. So now you know that that person you added is in your HIV group. So you can, without the obfuscation, you'll be able to play with the numbers to be able to figure it out in certain circumstances, I should say. Now, you could also approach it that, well, I'm only going to authorize people who have access to a limited data set, right? And we tried and tried to get that through our IRB, but they wouldn't let us do that. But that's a much better way to go. So if your IRB can agree that the authorized people are, are researchers and they should be able to look at a limited data set, that's a much better way to go. And then you can,
And that is what we have done.
that's what you do.
So one of the benefits of i2b2 is that you can approach it in different ways with open source. You can do various customizations. And what we have with our IRB and health system HIPAA privacy and security officers have allowed is, as long as you meet the requirements to view HIPAA limited data set, which we require you to do before you are enrolling in i2b2, you don't have to obfuscate, you don't have to have a minimum result size. And in Shawn's step 1 and step 2, we kind of have a step 1B where you can download patient level HIPAA limited data set data without having to go to the fully identifiable IRB approved data. But our IRB and health system have, as long as we meet the security and confidentiality and attestation requirements for accessing the limited data set, in i2b2 you can do that.
That's extremely good. It is. It's very good.
You would have to come to the EDW team for, you no longer have to come to the EDW team for it. Explicitly, all these posters have patient level data and didn't have to come to the EDW team.
Yeah. So that is very, very good. I mean, I'll talk more about that whole, but that it does. It enables a great deal. Yes.
What kind of IRB approval we need expedited or can we for this kind of?
Okay. So then, in our system where we don't have B, which I wish we argued forever, I should say. I mean, it was like 7 or 8 meetings, and they were just steadfast. So not until we got consented patients in the biobank with an i2b2 portal did we get to do what you guys can do here. All right. We do. So instead, we only have 1 and 2. And to go to step 2, you have to have, and you can do an expedited review. It only takes a couple of weeks. And then you'll get a number. You'll get an IRB number. And we know who's on that IRB. And then the provider has certain data types that they've requested on that IRB. And we actually, they request specific kinds of data, but they're on their honor to know, whether the data they request complies with what is on their IRB. We can always go back and look at what they got and then, do a backward analysis. But in that way, we did convince the IRB that, these are investigators who've gotten an IRB. I mean, they're not going to anyway. And it's hard, to figure out what data belongs in what bucket. So anyway. So there's always this negotiation, I have to say, about, where's the line, and sometimes the lines can be drawn kind of arbitrarily. And so when we actually designed i2b2, we actually have 5 lines. We have obfuscated data users. We have what we call DID users, which are, you can get exact numbers, but you can't look at individual patient data. We have limited data set users. That's the setting you guys are on. We have a DID. We have a text-enabled user, which if you put something in the blob of i2b2, this is kind of technical, but it can be a text blob. So in theory, it could be a de-identified text, and that's different than a limited data set, which has restrictions that don't always comply with getting even a de-identified text blob. But this 4th kind of user can get whatever that data is in the blob. So, and then finally the identified user, the one that can get identified data. So it's actually those 5 different levels. So those are your options. So then in our system, or okay, not in this RPDR system, once you get that IRB approval, now you get all that line item data, right? And you can get identifiers when you need them, because clinical trials, often you need identifiers. So only after many years were we able to take advantage of this limited data set, where in the Partners Biobank, we actually got consent, and the patients allow you to use i2b2 to get limited data, and so we do. And so we have actually 80,000 patients. I thought I changed that, but I guess not. Anyway, 80,000 patients now who have given consent. We get samples, and we put their data and their DNA information into i2b2. We genotype them all with the Illumina mega array. 1.7 million variants are genotyped for each patient. We also get RNA-seq and methylation data on the patients. And then those kind of get combined with the data from the healthcare system, as well as survey data that we collect on the patients. And we put the survey data, their consent status, the healthcare data, the genotype data, and some curated phenotypes, which I'll go into in a little bit, all to allow you to query by all of those things in i2b2. Okay, so what's i2b2? So I guess you guys know this, but let me just say, so the idea behind i2b2 was to be able to integrate all those different kinds of data. That was the point, right? Not just the data from the healthcare system, but all the different kinds of scientific data that you can collect on a patient, right? Genomic data, imaging data, survey data, all the different kinds of things that you can collect on a patient. It wants to be able to integrate together. And then on top of i2b2, so i2b2 is software, right? And it's software that allows investigators and researchers to go in and actually get their hands on the data. But we knew that the kinds of ways that we put into the initial product were going to be far short of all the different things that people wanted to do with the system. And so really the main focus of creating i2b2 is make it this portable and extensible application framework that allows us to add in new software modules that are built by the community. And that is absolutely the most critical thing that i2b2 has to offer today. And I think that you've actually done a lot of that here, which is exactly what the intention was. If you really take, I think many of you have never seen like just plain old i2b2 out of the box. It doesn't even do that much. It like does some queries and stuff like that, but it doesn't even do that much. All right. And here's the key to it, is this communities, right? So we have these community projects that have the different cells that are developed by people outside of that original core team, which can you can add plugins to the web client. You can add new kinds of clients like the Workbench. You can add new analytical modules on the server side, and you can add new ways that i2b2 can even access data. So all of the communication within the i2b2 system happens with web services. And behind every module is data and access policies and business logic. So you can wrap your healthcare data with kind of the standard CRC module, which many people do because we spent a lot of time, making sure it was fast and all that. But you can also wrap other kinds of data, right, with i2b2 that let you make a really robust ecosystem of data. And so at the end of the day, you get the data. This is the star schema, and I'm not going to go into that very heavily because it's just kind of like an artifact of, we tried to make the fastest way that you could access healthcare facts, right? And it turns out that the fastest way is, from a theoretical limit point of view, is to build a giant fact table in the middle of various dimensions, because your index, you're going to be able to build your biggest index on that fact table. Now, it's not always the best way to go because it's kind of hard to manage that big fact table. And so you're really kind of like doing a lot of work, right, to get things optimized so that basically those researchers and clinicians don't need to sit there waiting too long for their answer, right? Because that's the other thing, that they got bored very quickly, right? So if you spent like many minutes waiting for an answer, they'll just be like, forget this, right? So it's really, so we spend a lot of time, right? You all spend a lot of time getting the data together and into these structures so that it's as fast, basically, as it could possibly be. So in the center of i2b2 at Partners is a 2.7 billion row table, right? And you can have lots of other tables. I mean, you can have other little databases hanging off of it too, and that's kind of what we show you here. And then this is just what the i2b2 website looks like. Here's some of the implementations. So here's where I was going to, so this is actually a really old slide. We have about 3 times this number of implementations now. But you can see you were one of the first up there. And they don't all do it the same. So this is actually, this hospital, university, is one of the most productive, I would say, in allowing their clinician and researcher constituents, of which many of you are in the room, to use i2b2 kind of the way it was intended, right? Which is that it lets you really get in touch with the data, and that's really what it was built all about. And of course, there's the i2b2 web client out of the box. I don't think it even looks like that here, does it? Or does it? Does it? More or less. Okay. This is another client. So I told you you could put different clients on top of i2b2. This is the Workbench. The advantage of the Workbench is that you can make things like timelines, right? So we actually have a really nice timeline coming up in soon for the ACT program, and you'll be able to see that when it comes out in shortly. But here's a timeline that's existed for almost like 8 years in the Workbench, and it was very important for some reason. Each of these is a patient, and you can't hardly see them, but like each of these, this is a patient, this is a patient, this is a patient, and this is a patient. And you'll see the blue dots and the green dots, and this is time marching on. This is their prescriptions for bronchodilators and prednisone. And the study we had a hypothesis that patients who are responsive to prednisone have a different genetic determinant for asthma than patients who are not responsive to prednisone. And the way that we segregated our patient populations is we wanted to find patients who were commonly prescribed prednisone when they had asthma attacks and those that weren't. And you can see this patient, every time they have an asthma attack, i.e. they get bronchodilators, they get prednisone. This patient, they got prednisone at one time, but it's not when they get their asthma attack. Maybe they had poison ivy out here or something, who knows, right? So those two patients here go in those two different cohorts. And then these patients don't really have enough data. And so by diving into the healthcare data this way, you can often, from clues of how the data is kind of shaping out, divide your group, your patient population into these different stratifications, right? And that kind of gets you a lot of the way of the fundamental tenet of medicine, which is understanding different kinds of patients and then doing trials on them, managing them differently, and so forth. Then we had a problem. So our problem was that the more we tried to use the healthcare data for research, the more it became clear that the data was never intended to be used for research. It was intended to be used for billing and physician communication. So for billing, you have all kinds of issues with upcoding and people using different codes like depression all over the place when they don't even really mean it. So here's a receiver operator curve, and here's the random guess line. And if you relate the diagnosis of depression to the encounter of a patient who's seen for depression, whether they have depression or not has nothing to do with whether they're coded for depression. It's almost a random guess. So you'd be like, okay, well, that's it. We're giving up. This data is not going to be useful for anything. But of course, that's not true, right? I mean, there's lots of clues. It's not just diagnosis codes. There's lots of clues as to whether the patient has depression. Are they on antidepressants? How often are they getting their antidepressants? What do the notes say about the patient, right? So if you actually do that and you dive into use natural language processing to pull out some phrases about, that occur with patients who have depression, and you work it, you can get much better accuracy of these patients, right? With a positive predictive value of 87% versus 54%, right? So that became a very important thing to work on in terms of why is it that you need all these different kinds of data, right? You need all these different kinds of data. Why don't you just have billing codes and just that they tell you what the diagnosis is and you go from there? Because you need all the different kinds of data to truly understand the patient from all those reasons we started with, right? One, just to figure out what they actually have, because without all the different kinds of data, it's very difficult to figure out what the patient has. But by looking at all the different dimensions and types of data, you can actually do a pretty good job to figure out what the patient has. And you can stratify the patients like we did with asthma. And we do this with this kind of supervised learning technique, which I think many of you have probably done in this room. Create a gold standard of patients by going through, let's say rheumatoid arthritis. We want to figure out who has rheumatoid arthritis. So we get everybody with rheumatoid arthritis who has a billing code for rheumatoid arthritis. And then we take a sample of 300 patients out of that. And we go through them in detail. And it turns out about 60% of those patients will actually have rheumatoid arthritis. And they'll be classified. Those 300 are going to have about 200 patients that do and 100 patients that don't. Then we pull out features that we think are relevant to whether somebody has rheumatoid arthritis. And then we fit them with a lasso regression test, right? And those features then will give us a very accurate representation of who has rheumatoid arthritis. Now, that's for us to do, right? Us analysts to do. But it really just digests down to, we can do this for multiple diseases, feed those back as facts about what the patient actually has, right? And so now, clinicians and researchers can use that data, right, that fact, to determine whether a patient, they want to query and see if a patient has rheumatoid arthritis, not the billing code. And so that's very key in that we can use, we don't need to just use raw clinical data. We can use the derived clinical data in our queries. And so, for example, here, this is where we're doing a biobank query, but we have all these curated disease types, right, that are available with their positive predictive values right next to them. So you can actually use that, like here, rheumatoid arthritis, in a query itself. And this, of course, is very critical when you're doing a query like for genotype data, where here we've loaded all of those variants for, actually it turns out 20,000 patients, so it's about 13 billion facts. And now you can query, along with the other data, for patients who have a gene which has a variant in it, or the variant itself, and then whether it's homozygous or heterozygous. Okay. All the code for this, by the way, is available on the community website. So if you go to the community website, that community.i2b2.org, and you want to import VCF, genomic data that's in VCF files, all the code and all the ETL process is available, okay, right here. And you'll get exactly what you see here. Because now we can do a query like this, right? We can say, okay, we didn't do a curated phenotype for dilated cardiomyopathy, so let's use the billing code for that. But then let's use the curated congestive heart failure fact, right? Patients who have that fact associated with them, and the patients who have the Titin gene in this case, that's the affects a sarcomere protein, who are homozygous, and that variant is predicted to be protein altering. So these are folks who have that protein altering gene variant and are known to have congestive heart failure and are billed to have primary dilated cardiomyopathy. So you can do very deep queries, right, once you kind of build up all these facts. All right, so that's what we do, taking it a step further with the i2b2 system, as many of you have been working on. From there, we can do these distributed networks. So we have an emerge network where we use these methods to actually pool together the genomic data so that we can do bigger phenotyping types of experiments. We have something called PCORnet, which we have an i2b2 based PCORI network, which actually was kind of the beginnings of what then became the ACT network from a lot of our experience with this, where we have these 13 sites and we can do a query, in this case of hepatitis C, and we'll get the results from all these different institutions. And the way it does it is really very simple, because i2b2 is just a bunch of modules, right, with web services communicating back and forth. So just make kind of a master module, have it be able to go out and query the modules at all the different other hospitals, and then bring back all the data to one place. Yes?
Can you clarify, so the eMERGE network, is that federated i2b2?
No.
Or giving you clinical data at partners?
Yes. So the eMERGE network, so all of our eMERGE network, well, so about a third of the sites are on i2b2, but we haven't successfully put them in a shrine type of network. So now what we're actually working on, so you can put, so we have an OMOP data model. You can actually put i2b2 on top of OMOP for standard clinical data, right? It doesn't, OMOP doesn't hold other kinds of data, but it does hold the standard data. So you can actually put i2b2 on top of the standard OMOP data, and then you can query it using these mechanisms and put the genomic data in a separate repository, i2b2 straight repository. And that's where we're going to with eMERGE. And so even more recently, we have this ACT workflow, right? So the ACT is called the Accrual for Clinical Trials Network. It was developed out of NCATS. And the ACT network is a shrine network, kind of based on the experience that we got using our PCoreNet skills network, where you run a query on the shrine network. You figure out the feasibility, the step one kind of query, right? You can't get the patients. You can just get the obfuscated results. So in the shrine network query, you only get obfuscated results back. Then the good news is that you get those results back. You're like, so here's like 8 sites, which I really think would be good to engage with. And it turns out you've already done the query at their individual i2b2s, because that's how it works, right? Is it did the query on the modules that you have, for example, here at UAB. And then you can go in locally using your local policies to review the patients. And so then what we have is just a better, some other software that after you do your ACT Shrine query, you can go to your local i2b2, and it came out terrible, but hopefully the next slide will look better. I lost some of my resolution. Here, see, what it really looks like is this, right? So when at a local level, right, so somebody did a query, they figured out that UAB was the optimal place to do their clinical study. Then they need to find an investigator here, right? And here, you can get access to, it'll look like your i2b2 here. It won't look like the client. But the plugin, so this is just a plugin. So the plugin will let you do what you can do here, but you can't do many other places, which is look at one patient at a time in a limited data set. And then you can, as you check your patients off, they actually appear in the workplace. And then you can download those patients here, right, and recruit them. So that's a local workflow, right? It's not a shrine-wide workflow. All you can do at a shrine-wide level is just know what the counts are, and they're obfuscated counts at that, right, from each site. But at the local level, you can start with a shrine query that was specifically done at UAB, and a UAB investigator can use this workflow to recruit patients for clinical trials. Okay, so finally, in a couple of minutes we have left here, what's personalized medicine delivered into clinical care? So the idea is that the same workflow, the same ideas that we've used in i2b2 of finding similar patients and helping us understand disease can also be used in setting up clinical applications. Because it's the same idea of helping predict successful therapies and determining the next steps in diagnostic pathways. And so to link this together, right, i2b2 together with clinical care, we use something called smart apps. So smart apps are actually this idea of having an app that can run anywhere, including in an EHR, right? So that you can go from something that looks like this, right? And our Epic stuff doesn't look exactly like this, but it looks pretty close, I have to tell you. Do you have Epic here? No? Cerner, okay. I don't know what it looks like in Cerner, but I tell you, Epic it's the most obfuscated thing. So you get like 3 pages of stuff, right, back from a test. 2 and 9/10 pages is all about, like, you know, who, you know, what secretary processed it, you know, what, when it kind of, who's, you know, what billing system it went through and all this. And then there's like one little link that'll get you to the actual result. And a lot of times it's even hard to figure out like what the actual result is, because like before they even get a result, you'll have all those pages available, but sometimes the result's not even available yet, and it's even hard to tell. Okay, so the idea is that to go from something obscure, which is really made for a billing system, to something, again, just like we kind of did with i2b2, to something that's done for a clinician in this case, so that you can lay out your clinical data using FHIR services in the back end, and this smart app, which is really just JavaScript, I have to tell you, with some authentication protocols in front of it, and create something that is actually understandable in this way, returning cardiac test results, for example, to show what their cardiac risk factors are. And you can run it in, you can create lots of different apps, and you can run an app like this in different systems. So you see here it's running an i2b2, here it's running in an EHR, and here it's actually running in a PHR. And those, it's good, you know, even in old applications like the growth chart, right? So this kid looks like he's doing or she's doing very poorly, right? The bottom of the growth curve, and on a doctor's wall, that's pretty much what you're going to get. You're going to get a kid that's not doing well. But the fact is that lots of things go into computing a growth curve. And so when you do the computation for real, what you need to do is like figure out, well, what's the parent's height, right? And this kid is fine, right? The parents are short, all right? The kid should be short. And kids come in different body habituses, right? So you have to take lots of things into consideration, even for something as simple as a growth chart. Here, we have another case with kids where we are looking at MRIs, and we wanted to know if a kid had suffered from a birth trauma. So a lot of times, unfortunately, when a kid is being born, they get stuck in the vaginal canal, or the mother has trouble pushing the baby out. And so the question becomes, did the baby have a period of time where they didn't get enough oxygen? And that's called hypoxic ischemic encephalopathy. So you think that'd be an easy question. Do an MRI, and it does look different in somebody with HIE, and figure out if they have an episode of, if they were hypoxic. There's a problem. We don't know what a kid's MRI looks like. It changes every day. Because an MRI looks at fat and water. And a kid is born with a bunch of neurons and a bunch of connections called axons. And the axons get myelinated as they get older. And that's a good thing. They get covered with fat. And it's a way that the signal through the axon is able to increase its speed as they get covered. But kids do this for years after they're born. Every day, they're going to cover their little bit more fat over different areas of their brain, and that is going to make a different looking MRI. So that here, for example, is the same kid, and their MRI, you see it's changing quite a bit as they go from 99 days to 726 days. So you need to get a whole compendium of normal MRIs to compare your kid to that might have had a hypoxic episode. How do you do that, though? Well, there's a problem. What normal kid gets an MRI? Right? I mean, normal kid's not going to get an MRI. But it turns out that sometimes they do. And so you develop a phenotype in i2b2 that's normal kid. And normal kid then, and this is actually a normal kid here. Who knows why the kid got 5 MRIs? And by knowing what their outcome was, right, you'll know they're normal, and then you can do something like this, where you can, here's 5 kids, and now you can actually compare it to normal, and you can say, okay, so here's the comparison, and this kid, unfortunately, does have an issue here. This kid has an issue. It looks fine. If you just look here, it looks fine, but no, compared to a normal kid, it's not fine. This kid is fine, and this kid is fine, right? So by taking this a step further and taking the results that we get from compendiums that we put together in research and applying it to clinical care, we can use these apps to really mold the kind of intelligence that you develop in your research applications into something that really produces results in clinical care. So I'd just like to kind of review, so what is it that we've seen over the years? So precision medicine is really about these fine-grained classifications of diseases. And bioinformatics has been really instrumental in creating these tools. It's not just genomic medicine, it's applied everywhere, right? All different kinds of labs, imaging, all kind of form the nucleus of this precision medicine. And it needs new ways for researchers to partner with care delivery professionals to be able to actually deliver this kind of insight. So I said that there are only a few, this is only a very, very few of the folks who have contributed to i2b2 over the years, but it's still a big list. Here's some of the URLs that we have in the presentation that you can go to, and then and thank you very much.